So the second YPA presentation, Seeing is Believing, Unraveling Dementia with Lewy Bodies and Its Challenges by Dr. Nipuna Weerasinghe, Senior Registrar in Neurology, National Hospital of Sri Lanka. Nipuna is a Senior Registrar in Neurology, currently attached to the National Hospital, completed his MBBS with the Faculty of Medicine, University of Colombo with first class in Distinction Medicine, Pediatrics, Obstetrics and Gynecology and Psychiatry in 2017 and received his MD in Medicine from PGIM. So over to you, Nipuna.
Good afternoon, ladies and gentlemen. Thank you, sir, for those kind words of introduction. From a more broad physician's perspective to a niche in the field of medicine. So I'm sure some of you may be familiar with this movie, which is one of the movies which piqued an interest in neurology during my medical student days. So for those who do not know about this movie, this is based on one of the books written by a British neurologist, Oliver Sacks, who is known to have written several other, who's a medical novelist, and it portrays one doctor, Malcolm Sayer, played by the legend himself, Robin Williams, and the other actor, of course, was the well-known Robert De Niro. And what the movie portrays is the use of levodopa, the trial levodopa on a cohort of patients with post-encephalitic lethargica who came out of a coma or rather stupor state after 40 odd years. So this is a must-watch movie for any medical undergraduate or for anybody who is in the field of medicine for that matter. So fate was such that Robin Williams succumbed to a suicide in 2014, leading to an untimely demise. And it was only posthumously he was diagnosed to be having dementia with Lewy bodies. So ladies and gentlemen, just imagine in a first world country where advanced technology is available, a prominent figure goes undetected, leading to a drastic consequence. So this made me talk to you about dementia with Lewy bodies today, a condition perhaps which is going under the radar in our setting. So seeing is believing, unraveling dementia with Lewy bodies and its challenges. So within the next 25 to 30 minutes, I'll be talking about the history and the pathology and the pathophysiology of dementia with Lewy bodies, some clinical features, how to diagnose, and some management principles. So this picture is also not a unfamiliar picture for anybody in neurology. So dementia with Lewy bodies being a neurodegenerative condition, we talk about two main types of neurodegenerative conditions, the alpha-synucleinopathies and the tauopathies. So this is based on the pathology which you find on the brain. So you have primarily alpha-synuclein deposition intracellularly in these disorders, and tau protein deposition. I'm just talking broadly, but this goes on. There are a lot of details which follows through, but that is not relevant here. So tau protein deposition in these disorders. So as you know, the idiopathic Parkinson's disease takes the bulk of alpha-synucleinopathies, with the motor predominant symptoms. And then multiple system atrophy with cognition spared, you have another prominent alpha-synucleinopathy. And then tauopathies, you have the bulk of it, the cognitive disorder, Alzheimer's disease. But of course, Alzheimer's has several other pathologies behind. It's not only the tauopathy or the tau protein deposition, and then the progressive supranuclear palsy and the corticobasal degeneration. So perhaps few years back when we were medical students, we learned this as Parky plus. You have Parkinson's, idiopathic Parkinson's disease, and Parky plus, right? So then it became atypical Parkinsonism and so on. So the terminology is ever changing. But so these are the disorders we generally talk about. So DLB or dementia with Lewy bodies is an alpha-synucleinopathy. So the primary pathology is alpha-synuclein deposition. Right. So going back, so in 1817, James Parkinson, who is a surgeon by profession, published the first ever description, an essay on a condition he coined the term paralysis agitans or shaking palsy. And there he described these patients to be having senses and intellects being uninjured. So now, years later, now we know that that's not true. Even Parkinson's disease has an element of intellect being affected, and dementia with Lewy bodies has the same pathology as Parkinson's with predominant cognitive component. So this is an interesting, I'm a fan of history, so I'll be going through a bit of history with you. So this is a picture taken at the Royal Psychiatric Clinic in the University of Munich, Germany. And this individual is Alois Alzheimer, who is the one who described, who is named, the Alzheimer's disease is named after him. So this is his team, Alois Alzheimer's team. And circled here is the person who described the intracytoplasmic inclusions, and after which it was named as Lewy bodies. So his name is Fritz Lewy. That is 100 years after James Parkinson describing shaking palsy, so in 1912. So interestingly, in Germany, when Hitler became the Reich Chancellor, all the non-Aryans were removed from their posts and they were sent out of Germany. So Fritz Lewy, later on, he called himself as Frederick Lewy. He went to US and established himself as Frederick Lewy. And it says in history that in Germany, actually, neurology was a specialty under psychiatry, and Lewy is one of the people who actually brought it out as a specialty out of psychiatry as a separate specialty as neurology. So years later, he was given the due credit by naming these cytoplasmic inclusions he described as Lewy bodies. So this is considered as the pathological hallmark in idiopathic Parkinson's disease as well as in dementia with Lewy bodies, where you have round eosinophilic intracytoplasmic inclusions, which are amorphous with a surrounding halo. So this contains alpha-synuclein, ubiquitin, and proteases, and commonly seen in idiopathic Parkinson's, dementia with Lewy bodies, and to a very less amount seen in other neurodegenerative conditions as well. So how this form is, you have alpha-synuclein monomers. So later on, they bind themselves into oligomers and then fibrils, and with the inclusion of ubiquitin and other neurofilaments, the Lewy body is formed. So this later on in 2000, I think late 2003, Braque described that this deposition of Lewy bodies is happening in a consequential manner, starting from the peripheral and enteric nervous system, medulla oblongata, and then it goes on to the neocortex. So this actually interestingly describes how now in practice we know this idiopathic Parkinson's or any alpha-synucleinopathy for that matter has a pre-motor component where the motor symptoms occur years later, but if you go back in history, they have an element of anosmia. They might have an element of sleep behavior issues, sleep behavior disorders. They might have depression or constipation, some autonomic symptoms in the past. So this is probably what Braque and his colleagues described, is that the Lewy body deposition starts off in the peripheral or the enteric nervous system as well as in the autonomic nervous system initially, and then goes up the ladder to the neocortex. So it might describe why these pre-motor symptoms are occurring, the autonomic symptoms, the sleep symptoms, as well as the depression, as well as anosmia because of the limbic system involvement before the neocortex or the subcortical nuclei are involved. So this can actually describe the progression of these Lewy body disorders in general, the Lewy body pathology. So Dementia with Lewy bodies is actually one of two disease entities. So Lewy body dementia is the umbrella term we use, where you get a patient with dementia who is having Lewy bodies, or rather you can call it nowadays they call Lewy body disease. So this is divided into two. So this is actually for research purposes they divide it. So within 1 year of the motor symptoms, as well as after 1 year of the motor symptoms. So Parkinson's disease dementia is another disease entity we described. If the dementia, the cognitive impairment occurs 1 year after the movement disorder or the motor symptoms come. If the motor symptoms, or rather the cognitive symptoms, come within 1 year of motor symptoms, still the patient comes under dementia with Lewy bodies. So why this significant? I mean, why this differentiation is significant? Of course, for research purposes, it is significant. And a team in East trial, they actually went through these patients and then found out some overlaps as well as some dissimilarities. So the overlaps includes the rigidity, the akinesia, of course, which are part and parcel of Parkinsonism, the cognitive impairment, frontal dysfunction, visual impairment, mood disturbances, mild language, the REM sleep behavior disorder being alpha-synucleinopathy, obviously in Parkinson's as well as in dementia Lewy bodies, you will see that, and the neuroleptic sensitivity. So that which the details are come to later. So those are overlapping features between PDD and DLB. There are some very subtle similarities. One is the cognitive dysfunction characteristics. So you have deficiencies of attention is greater in DLB. And then verbal memory, episodic verbal memory tasks are generally impaired in DLB. The tremor component is less frequent in DLB, more commonly seen in PDD, or rather Parkinson's disease dementia. And then hallucinations more frequently seen in DLB. Medical student days, what we know is DLB is visual hallucinations and DLB. So DLB, it's, I mean, it's something more than just visual hallucinations, but it does play a major role in DLB. And then of course the timing, this 1 year rule. And the other main thing is the visual hallucination, spontaneous being, and of course PDD patients also can have spontaneous visual hallucinations, but more commonly what they have is DOPA induced, or when we start them on DOPA itself has a tendency to cause psychotic symptoms like visual hallucinations. So you can have drug naive case of visual hallucinations in PDD, but generally spontaneous visual hallucinations seen in DLB. So epidemiologically, yes. So 1 to 2% of those aged above 65, they have DLB, they say. But even though it is 5%, Alzheimer's is, of course, the bulk cases of dementia patients we see is, of course, having Alzheimer's disease. But the second most common cause of dementia is dementia with Lewy bodies. And you have to remember that there is a considerable overlap. You can have a lot of patients with AD and DLB overlap. So difficult patients, because dementia with Lewy bodies have this neuroleptic sensitivity, which we'll be talking about later. So Alzheimer's disease patients, you have to be careful, who are resistant to treatment, who are not getting better with your normal antipsychotics, they might be having a component of dementia with Lewy bodies. And I think, of course, PD patients, the more they survive, the much more chance of getting dementia. So can it kill? Yes, of course, with the case of Robin Williams, we know. So higher mortality compared to the general population. And they have found that higher mortality, there are some risk factors they have identified among these patients. One is if they have a Alzheimer's disease CSF profile. So if the CSF profile is, what I mean by the Alzheimer's disease CSF profile is the tau to amyloid beta ratio. So you have, if the tau to amyloid beta ratio is more than 0.5. So amyloids, even though alpha-synucleinopathy or alpha-synuclein intracellular depositing is the pathophysiology, there is an element of amyloid deposition extracellular also occurring in dementia with Lewy bodies, just like in Alzheimer's. But the deposition is less marked compared to Alzheimer's. So if the tau to amyloid beta ratio is more than 0.5, which is tau is more than amyloid beta, pointing towards Alzheimer's, they say the mortality is higher in patients with DLB. And if there is hippocampal atrophy, which is not a commonly seen thing in DLB, but that is again pointing towards a possible AD-DLB combination, the survival may be less. So what they say is in DLB, generally after diagnosing, the survival is generally 5 to 8 years, maximum 10 years. But there are cases where within 9 months, patients have passed away. Right. So coming to diagnosing or clinical features. So this is basically a historical diagnosis. You basically take a good history and diagnosis as the bulk of neurology. So you have three main symptom domains to talk about: cognitive, psychiatric, behavioral, and physical. So based on these, the revised criteria, the fourth consensus report was laid out, that is back in 2017, which is from the Neurology journal. So here we talk about the essential, of course, is the dementia, where you talk about a progressive cognitive decline, which is affecting activities of daily living. That is your definition of dementia. So dementia is a must to diagnose DLB. And then the other the core clinical features. So fluctuating cognition, recurrent visual hallucinations, REM sleep behavior disorder, and of course the Parkinson, the motor manifestations. So coming to the first one, cognitive impairment. The cognitive symptoms, you have attentional or executive function, visual processing deficits. So Alzheimer's, more we talk about memory impairment, short-term memory impairment initially, and then the memory impairment gets worse. But here, more or less in DLB patients, what we have is attentional issues and mainly executive function issues. So we talk about this intersecting pentagon, which we ask the patients to draw when we do the MMSC. So they'll have difficulty drawing that. The complex figure copies, you ask them to we draw a complex figure and ask them to copy it. And then block designs, you draw a design in a block setting and ask them to copy it. So they will have difficulty in doing those. And these are called pareidolia tasks. So where they actually, you have very meaningless visual patterns, and you ask them to recognize anything, I mean, standing out, any figures they can observe. So they are having difficulty in getting this task done, right? So they actually, interestingly, what they have found is they come out with, because they have visual hallucinations, when we ask them to do these tasks, they come out with very meaningful, for them meaningful patterns in these meaningless visual patterns. So these are pareidolia tasks. And then this, what you call cognitive symptoms, are fluctuating, right? So this fluctuation is very interesting, which is not generally seen in Alzheimer's disease. So generally, this can fluctuate, like here you can see from mild cognitive impairment can come to normal cognition at times, again back to mild cognitive, and can frankly go to dementia. So this fluctuation can occur within days, even within months, within years even. So you have this dementia cognition fluctuation scales, where you can ask like questions like, do they have fluctuation in their mood, in their level of functioning during the day, or how the fluctuation occurs during the day, during the month. So this fluctuation is also objectively assessed in these scales. So, and importantly, now we know delirium is very closely going on differential when it comes to dementia with Lewy bodies, because delirium also, generally, more than memory impairment, what they will have is cognitive, mainly executive functions as well as attention issues. And they will also have fluctuations similar to DLB. So differentiating main feature would be dementia, DLB versus delirium would be the precipitant. So delirium will have a very acute precipitant, either a stroke or maybe an infection, maybe a UTI. So any precipitant, acute precipitant causing fluctuating cognition, it's more of a delirium. But without a precipitant, if it's a progressive dementia, or rather fairly subtle dementia in the background with subtle fluctuations, more in favor of dementia with Lewy bodies. So coming to the second core symptom, the visual hallucinations. So they can have recurrent complex visual hallucinations, and 80% of the time, well-formed visual hallucinations, and what they say is very pleasant visual hallucinations. People, children, animals, maybe deceased family members. Passage hallucinations is in the back. If they say, if in the back of them, they will feel like somebody's there. If there's a passage, they will feel somebody's there. And visual illusions, before the hallucinations, illusions will come. Illusions is, if they see some object, they will recognize it as something else. And interestingly, 30% of the time, they can have auditory hallucinations as well. Even though we say auditory hallucinations is most of the time non-organic, there is an element of DLB which can present with auditory hallucinations. And what they say is, these auditory hallucinations are generally human voices, what they listen. More than music or other sounds, they will hear human voices. Right. So these are some of the interesting things Western people have come up with. So I can turn the chair into a bear or the computer screen into a hat. And they can feel sometimes spiders, mouse was running in the house, squirrel was running in the house. So these are called passage hallucinations. And then part of the plate becomes an octopus. Part of the book they see is as a bird. Another thing is delusions. So they can have delusions. So this is actually a famous painting. This picture is based on a famous painting. I think this is one of the Roosevelt's State of the Union addresses. Based on that, this Thanksgiving picture. So this patient will be seeing, this is called Capgras syndrome or the imposter syndrome, where there's a disconnection between emotion and picture. There's a disconnection. So their own family members, they don't recognize. Right? So this is called, they think they are imposters. They call Capgras syndrome. So this is also a recognized entity within dementia with Lewy bodies. And these are some interesting things which I came across with regard to one of my patients I've seen with dementia with Lewy bodies. So this is one few things she came up with. This was a 78-year-old lady who few months back she was telling Mama සිල් ගන්නකොට මගේ පිටිපස්සේ චූටි ළමයි වාඩි වෙලා ඉන්නවා පෙන්න. So these, of course, these images are from AI generated images. And then බිත්තියේ ලස්සන මල් ගොඩක් පෙන්වනවා. Something like this. And then as වහගෙන ඉන්නකොට සතෙක් ඇවිල්ලා මගේ කටේ වහනවා වගේ දැනෙනවා. So these are not very scary hallucinations. They are very, some are very pleasant hallucinations. Right. So coming to the third co-symptom, that is the REM sleep behavior disorder. So during REM sleep, you know, the tone is generally reduced. So that's why during the REM sleep, we cannot, I mean, because our tone, we are atonic, we won't be acting out our dreams. So in alpha synucleinopathies, our MSA or multiple system atrophy, DLB, as well as in idiopathic Parkinson's disease patients, you have this absence of atonia. So who will suffer? Your bed partner will suffer. So most of the time, so if you just Google said, there will be pictures of wives being beaten by their husbands during sleeping. So because of the absence of atonia. So these are our patients, a bit of a difficult thing to take in history because some of our patients don't have bed partners. So most of the time, husband and wife, old individuals, very rarely they sleep together. Most of the time they are, but so what we generally can ask is whether they are making sounds at night, whether they are shouting at night, whether they are making a big fuss at night, something like that. Right. So, and then the fourth one is, of course, the motor features of Parkinsonism. The typical one, the stoop posture, the tremor and rigidity, akinesia, and so on. And interesting, this is in DLB patients. We know in IPD, we talk about asymmetrical Parkinsonism. And this asymmetry persists. Right? Generally, first starts unilateral, asymmetrical, bilateral, and then this asymmetry persists. But in DLB, it's generally symmetrical Parkinsonism is seen. And 85% of the time, this Parkinsonism comes. And then rest tremor, like I said before, it's not very commonly seen. So those are the core ones. Supportive clinical features, mainly we talk about the antipsychotic sensitivity or the neuroleptic sensitivity. So you have to be careful. As physicians, you will be prescribing risperidone, quetiapine, and olanzapine, whatnot to old individuals. You have to be very careful when you are prescribing these because these antipsychotics come with a black box warning because these can lead to very detrimental consequences in patients with DLB if you have not recognized it because because of their pathology, they have pre-existing nigrostriatal, so in the substantia nigra, there is dopamine deficiency. And you act with dopamine antagonists or dopamine blockers, they will end up having worsening of dopaminergic activity and they will come with worsening of Parkinson's, or rather mainly the bad consequence will be neuroleptic malignant syndrome. The autonomic features will be the very detrimental, the cardiovascular side effects, so resulting in increasing mortality. So that you have to keep in mind, right? So mainly we talk about the first generation or the typical antipsychotics, haloperidol and all. And then of course, among atypical ones, risperidone and olanzapine are not very good to be used. And then anticholinergics have the same effect, and several other drugs you have to be careful when you are using. And then coming to the indicative biomarkers, or what we call the supportive other biomarkers other than the clinical features. So one is the dopamine uptake, the dopamine transporter uptake on the SPECT scan. So this is in a normal control. You can see the dopamine uptake is quite normal in the basal ganglia. And Alzheimer's also, you don't see that. This is called the coma sign in Alzheimer's disease. And you get the full stop sign in the DLB patients because of the reduction in the dopamine transport uptake in the basal ganglia. This is a SPECT. And then in MRI, in a normal control, you can see the hippocampal, the middle temporal lobes are quite normal. And DLB, you can see marked atrophy. Or rather, in Alzheimer's, you can see marked atrophy of the hippocampus. But in DLB patients, it's not so common. I mean, it's not seen. You don't get that hippocampal atrophy you see on a patient with Alzheimer's disease. And these are, of course, again, high-fi things to be done. These scintigraphies, myocardial scintigraphies, because of the post-ganglionic nerves, the sympathetic nerves can get affected. So because of that, you get this, the MIPG scan of the heart can be useful in diagnosing, helping with the diagnosis of DLB. And this is a polysomnography where you can see, now this is the EOG. EOG is the eye movements. So in REM sleep, you get eye movement. So during eye movement, these are the electrodes detecting muscle activity. But in a patient with DLB, you can see now, normal control, you will have no muscle activity. You will have atonia during REM sleep. But here during REM sleep, you will have increased tone. So you will have, these are like in subclinical cases, you can diagnose REM sleep behavior disorders using polysomnography. And then this is an FDG PET scan, which can be useful because you have in FDG PET, you have occipital hypometabolism in the DLB patients as opposed to Alzheimer's disease. So because of the occipital hypometabolism, with sparing of the cingulate gyrus, you get something called cingulate island site. So this may be useful in the future when we have FDG PET and SPECT scans more frequently, but these for the time being, these are more restricted to the West rather. Right. So coming to management. So basically the cognitive impairment you manage with the usual donepezil, the rivastigmine, the memantine, the acetylcholinesterase inhibitors and the NMDA receptor antagonists, which are quite proven to be very beneficial in dementia with Lewy bodies. And the psychomotor slowing again, the syndopa, the levodopa may be quite helpful because they have an coexisting Parkinsonism, which may be causing the slowing. And then the motor features, of course, with that and physical therapy. And recently, about several years back, it was shown to have a disease-modifying effect in Parkinsonism. So that can be useful, physical therapy and exercise. And then for the psychotic or the hallucinations, the delusions, like I said, risperidone or olanzapine may not be the most useful drug. So quetiapine is quite useful. Start with the lower dose and go up. And then clozapine. In our context, clozapine can be used, but you have to be very careful because clozapine can cause a lot of cytopenias and they're generally restricted to be used by psychiatrists. But in 2016, FDA came up with FDA approval was given to a new drug, which is a selective serotonin inverse agonist and antagonist, which is known as pimavanserin or Nuplazid, which is not available in our context, but which has been shown to be very effective in patients with dementia with Lewy bodies to address the hallucinations and the delusions. And of course, the psychiatric, the depression can be managed with antidepressants, fluoxetine, sertraline, and so on. The anxiety, again, with the same drugs. Insomnia, maybe melatonin will be useful. Again, some of the antipsychotics may be useful. For the REM sleep behavior disorder, melatonin as well as clonazepam before going into bed. So these medications is coming from a review article in the Continuum Journal with regard to Lewy body dementia. So with that, ladies and gentlemen, I just want to give you a window to the entity of dementia with Lewy bodies. So DLB or dementia with Lewy bodies can kill. So better not miss it. Keep it in the back of your mind whenever you're seeing a patient, an old patient with dementia, with maybe Parkinsonism. And all hallucinations and delusions are not primary psychiatry, not all the time. And the other thing is neuroleptics, your olanzapine, your risperidone can kill. So I'll like to end with, again, this is Robin Williams, because after he passed away, his wife, Susan Williams, started advocacy, for dementia with Lewy bodies, a program called Spark. And this is just a video, just a 1-minute video on this. So with that.
For me, if it would be anything, it'd be a neurologist because it's just the brain fascinates me. It's quantum neurology, it's quantum physiology, that the moment you think you understand it, it comes out with something else.
Looking at how Robin's brain had been affected, this was about as devastating form of Lewy body dementia as I had ever seen.
It makes sense why he was experiencing what he was experiencing.
In terms of Robin's case and in terms of a lot of these individuals, they do have insight.
The fear is when you start to think you're losing the spark, when the ember is starting to glow. That's a deep, deep fear for creative people.
It's like someone who is sinking in quicksand and you've got them. Like, I can hang on, but I don't know how this is going to end.
It's not a singular story. It's one that is an example.
The estimates are that up to 1.4 million Americans have one of the Lewy body dementias.
Everybody deals with grief in their own way.
Anything I'm doing for us. So I'm a mother, a wife, a caregiver, I'm a widow, and I am a witness.
Thank you. It was to be for a few questions.
Brilliant. I also went through Robin Williams' experience or what do you think were the reasons that they missed the diagnosis? Because, this is in the US, he was a very popular figure, and the healthcare signs were all there. He was missing his lines, he was frustrated that he could not be able to say. And they only could diagnose it as post-mortem because his brain was just literally everybody. So what do you think were the causes? That is one question. The second question is on benzexol. In Parkinsonism, we still use benzexol for tremors, but it is well known to cause hallucinations. And in the West, they don't use benzexol because they feel it impairs memory. That was the question.
Yeah, so with regard to the first question, I'm not sure how deep he was investigated. I'm not sure about that. But of course, if you go through his last couple of the story, how he was during his last couple of years, all the telltale signs were there, like you said. But I don't know how it was missed in sense. I mean, in a setting where FDG patent, all the investigations are available. It baffled me as well, sir, why it was missed. Second question, of course, benzexol we are using quite frequently in our context, but in the context of dementia with Lewy bodies, anyway, anticholinergics are not. I mean, it doesn't have black box warning, but still you have the risk of the high mortality or the worsening of the motor manifestations with anticholinergics in the context of dementia with Lewy bodies. So that risk is always there when you're using benzexol. So, but for the tremor component, we mainly use for the tremor component in our context. But I would think clonazepam would be a better option than benzexol in the context of dementia with Lewy bodies. For that matter, even if you're thinking with PDD, Parkinson's disease dementia. But I think we have Wim Sarasa also in the audience if there's anything to add. So,
I don't use benzexol at all. So, coming back to this case, it's very interesting that how, why did he commit suicide?
Because of the, I thought it was because of the hallucinations, which
So,
he tied the.
So the neuroleptic sensitivity in these patients. So, how do you think we should be managing these hallucinations? Because they are, as you said, like if they are drug naive, we got to think of DLB as opposed to PDP. So, in cases of drug naive hallucinations, where you are suspecting, so you said like clozapine, I mean, we don't really use much clozapine as neurologists, and we psychiatrists do. And I have found that clozapine is not so effective. Receptor blockage, I think Kashi would probably agree. It's not so effective, and always the risperidone and olanzapine does work. So in this case, it's a risk, of course. So how do you think we should be managing?
One thing is if we can get down pimavanserin, that's quite useful. From practice wise, I haven't had the exposure of dementia with patients as much. I've only managed about 3-4 patients. So I don't know how. I mean, as guidelines say, quetiapine is more less risky than risperidone. But I read around it recently. In Australia, they are preferring risperidone over quetiapine in their guidelines. So probably start off with a low dose of one and then see whether the risk.
Always more practically it's going to. And also just another point about the dementia here is because I think the Lewy bodies are more in the periphery rather than in
the hippocampus.
There's so much overlap of symptoms and signs of, DLB and Parkinson's. So it will be very difficult for young physicians to, separate the two, but there is so much overlap. So how useful is this imaging and how accurate are they? differentiating these two conditions?
So Parkinson's disease and Parkinson's disease is more of a motor predominant disorder rather than a cognitive. So cognitive impairment in say idiopathic Parkinson's disease, it will anyway take some time for the cognitive impairment to take place. So clinically, when the patient is presented, it's of course history and examination which will differentiate DLB from idiopathic Parkinson's disease rather than imaging. Imaging, I think I would not, I mean, imaging, you cannot advocate to diagnose either DLB or idiopathic Parkinson's disease for that matter. So I would say we would do imaging in all of these neurodegenerative condition to go for to find the underlying treatable cause, something like maybe a secondary cause like maybe Wilson's or some other neurodegenerative cause which may go missed. So for that we do rather than to diagnose. So that's what I would think. So these are, I feel both of these diseases are more clinical and like history and examination would be the primary thing which can be used to diagnose it.
Yeah, Dr. Balu. Thank you. I was intrigued by the question about why the diagnosis was listing of impedance. I don't know the answer, but I think one lesson that I try to think is that the chances of disease dementia in highly accomplished people is very high because they perform at a very high level, and therefore, of course, it doesn't affect so much for medium-sized work, but in the early stages, it will be difficult for a doctor who is just seeing the patient for the first time and comparing that highly accomplished person with the ordinary person, and easy to miss the drop in the cognition or things like that. I remember this one patient I had who was a very well-known lawyer, very famous person, now he's dead. He came, he was actually brought by his wife almost by force. And because he thought there was something wrong. And he had a completely normal social kind of interaction with the institute. He answered all my questions and he seemed to be very on top of the game. But then luckily his junior lawyers came with him that day. And then I asked him, then there are two. I asked them something. They said that he's hopelessly capable. Now, so much so that he's protecting the deficiency from the clients by secretly having the case themselves. So then I sent for an assessment and it was very bad image. But he could have gone to any party and had a normal social outlook. So I just learned that this and highly accomplished people they do this because they compare their interaction with ordinary people. That's what I wonder if that's one reason. Any other questions? So in the absence of any other questions, it's just thank Nipuna for that excellent presentation.